Well, thanks for attending today's webinar. I'm Dave Little from the Scottish Drugs Forum. I wanted to say a few words of introduction. It's maybe stating the blindingly obvious to say that our addiction services are under considerable pressure at the moment through staff illness, self-isolation and redeployment. Government has given reassurances that addiction services will be classed as essential services and have assisted us in putting together guidance on contingency planning for people who use drugs and COVID-19. Our first version of this was published on the 19th of March. Yesterday, the Minister and the CMO sent a joint letter reaffirming the need for local planners to see addiction services as essential, which is a very positive move. We plan to update the guidance to include more specifics on homelessness, benzodiazepine prescribing, stimulant users treatment, and the Home Office emergency powers regarding the Misuse of Drugs Act. Following the release of the guidance, SDF put together a key informants group with representatives from across Scotland. It was clear at the first meeting of this group that there were specific issues emerging re pharmacy provision, including, for example, reduced hours, queues outside the pharmacists, and people dropping out of services. As well as alerting government, we felt it was useful to share current practice more widely across Scotland, and hence we decided to put in place a series of webinars on aspects of the problems we are facing. And this is the first of those, as I've said. We are delighted to have 3 speakers from across Scotland. Carole Hunter, lead pharmacist with addiction services in NHS Greater Glasgow and Clyde. Tracey Clusker, nurse team manager in Lothian. And Laura Rothney, senior nurse practitioner for Aberdeen Substance Misuse Services. The plan is that they will all speak for about 10 minutes, and then we will have an interactive question and answer session. If you look at the sidebar to the right of your computer, you will hopefully see a questions tab. So please add any questions you have. Austin Smith, our policy officer, will be looking at these and summarize key issues being raised that can then be put to the panel. Any answered questions we will endeavour to follow up after the webinar. So that's me by way of introduction. I'd now like to ask Carole Hunter to speak to us. Over to you, Carole. Thanks. Carole, you need to unmute yourself.
Sorry. Thanks.
You're there now. That's good.
First glitch of today. Thanks very much to SDF for inviting me to take part in this webinar, and I do feel privileged to be your first speaker, either your first speaker or your first guinea pig, I'm not quite sure. So I reflected recently. I've been a pharmacist for quite a long time now, 41 years in fact. And the challenges that pharmacy are facing at the moment are definitely unprecedented, certainly in my working lifetime. So I've got 10 minutes, which I'll try and stick to. I'll give you a bit of background on the pharmacy figures, some of the challenges and the contingency plans that are in place, and the impact that that's having for OST patients. Pharmacies are very busy places. There's around 1,250 community pharmacies in Scotland. I work in Greater Glasgow and Clyde, where we have 291. They have a significant footfall, daily footfall, and over 650,000 people visit a pharmacy every day. And we know that there's roughly 25,000 OST patients who dispense their medication. The average number of prescription items that any pharmacy dispense each month is around 7,000. So the sudden emergence of COVID-19 has posed huge challenges in maintaining what is an essential pharmacy service, particularly when you take into account social distancing requirements and the staff shortages alongside a huge increased demand. If we all think back to the early stages before we went into a complete lockdown, And you think about the way that supermarket shelves were stripped completely of essential items like, you know, food, pasta, toilet roll, hand sanitizers and all of that. The initial demand for prescription items in pharmacies was of that same kind of order. So that increased demand created significant other challenges for pharmacy in terms of obtaining drugs, storing them, all the security associated with that, with the increased stocks that were needed to meet the demand. And they had to reconfigure premises at the same time to comply with social distancing requirements. So what I want to do is turn specifically to the impact that has for OST patients. Now we all know, and I assume everybody on this webinar will know, OST is an evidence-based treatment. It protects against fatal overdose and promotes health and recovery for individuals, and it has wider community benefits, including reduced criminality. So the challenge for drug treatment services, for GPs, for pharmacists, has been how do we keep people engaged in treatment? And the aim has to be to minimise public contact for patients, and that comes from a requirement for daily attendance, and to reduce the impact on community pharmacies, because it is essential. We do need to keep that network functioning. Prescribing and dispensing has to be risk assessed and has to be as safe as possible in the current climate. Now, I work, as I said, I work in Greater Glasgow and Clyde, but I have specialist colleagues across Scotland, some of whom are probably listening in, and please don't ask me any difficult questions. So they're in all the health boards across Scotland and who've been involved in this work, and they can be contacted locally for advice, and they're able to provide advice and support to prescribing services and to pharmacies. So as I said, all prescriptions should have been reviewed and risk assessed to reduce supervision and increase the periods between the instalment dispensing. And the aim is to reduce the patient contact and the public contact exposure, and reduce the pharmacy workload to some sort of manageable level. Sorry, I seem to have been locked out.
Carole, you know, we still hear you.
I got locked out there. I had a strange sign. Anyway, that's the second glitch. Don't know where I got to, what you heard, but Greater Glasgow and Clyde, pharmacies have agreed to reduce core hours, so they are open to the public between 10 and 5, with an hour closed for lunch. Now the staff are there between their normal 9 till 6 hours, but the closure time, the restriction in hours, is to allow them cleaning time, all the surface wipe down that has to be done, and deal with the backlog that this workload has inevitably caused due to the increased demand and the reduced workforce. I want to be quite clear, this is not about eliminating supervision. Supervision is still required, and it's still, we do need to recognise there are a number of patients for whom regular collection and supervised self-administration remains an essential element. And the review and the risk assessment should identify areas such as child protection, for example, where the home environment would be unsuitable for increased take-home doses. And I think that's particularly important when you look at the extended school closures that we have at the moment. And there's adult support and protection issues in terms of including patients who could be at risk of coercion to divert prescribed doses, particularly vulnerable groups who may have had daily supervised doses and suddenly given 2, 3, 4, 7 days supply at a time. And the risk to the community from diversion of controlled drugs. And there will be new starts, new patients who will require treatment to come into treatment, and I'm sure my colleagues who are speaking after me will talk more about that. There'll be prison releases, and those who will require more contact and supervision particularly during the titration phase. I think for me the answer is, one of the answers is communication, and that is key. It's very easy to say that, it's not always so easy to implement it. But it's communication amongst the drug treatment services, the prescribers and the pharmacists. We need to work together on this. We need to be given consistent messages. We need to communicate on opening hours restrictions or cutbacks in opening hours, restricted services, any changes to phone numbers, for example. Information to patients has to be consistent, and the pharmacist should be involved in these individual risk assessments. Now, Dave did ask me to say something about the legislation, which I'm going to touch on briefly. The COVID-19 pandemic is placing enormous demands on health and care services, including pharmacy. And although health, as we know, is devolved to Scotland, all of the legislation governing medicines is reserved to Westminster. So the UK government is looking at emergency legislation to ensure continuity of supply of controlled drugs. On the 1st of April, the Home Secretary wrote to the chair of the Advisory Council on the Misuse of Drugs with proposals for a set of temporary measures. And the ACND responded on the 7th of April, providing advice and recommendations. And you can access that on the Home Office website. So in summary, the three measures are emergency, looking at extending the emergency supplies of controlled drugs for those who are in ongoing treatment, extending serious shortage protocols to include controlled drugs. That's protocols that allow pharmacists to make changes in brands or strengths, or replacing capsules with tablets, for example, and also allowing variation to the frequency of instalment dispensing. So I can't finish without saying something about naloxone, which I think is really important at the moment. In any time of social disruption, there is a recognition that alcohol and drug use in the population increases, and I think we are all seeing that. So if you combine that with the increased demand and the decreased availability of access to services, including pharmacy services, it's vitally important that naloxone coverage is increased. People at risk, families, carers, basically anyone who's likely to witness an overdose should be offered and supplied with naloxone. I had another report this morning of one of my colleagues in community pharmacy who had to administer naloxone recently. So this is a role, this is everyone's responsibility. And I just want to finish by saying that the role of community pharmacy in protecting the health of the individuals and of the wider community should not be underestimated. And that's me finished. Thank you.
Thanks very much, Carole. That was great overview. Can I ask Tracey Clusker to speak next? Tracey.
I'll just
Just bear with us while we're putting this together. I can hear you. Yeah.
You see me?
We can't see you, but we can hear you.
You see me now?
Yes. Okay, we can see you now. Over to you, Tracey.
Great. Thank you so much, and thank you, Dave, for inviting me on to speak today. I'll just continue to talk about from a service level how we've continued to deliver OST during these challenging times. I'm currently the team manager for social work and nursing out in Mid-Lothian Substance Misuse Service, and I also do some work with the Scottish Drugs Task Force around the medication assisted treatment standards. So we are trying to continue to work with those standards, keep people safe, keep people in treatment as much as possible, and we really want to reach out to people at this challenging time who may not be in treatment and are currently at risk of drug-related harm. In terms of Lothian, have a wide contingency plan, and similar to what you've shared from a Scottish Drugs Forum point of view, we've looked, as Carole said, along with pharmacists, family members, and people who use our services and are prescribed, to look at what the risks would be in terms of reduced dispensing. Now, we have done a sort of red, green, amber risk assessment. What we have done is we've done it with the patient and their family and risk assessed each case, seeing what kind of, rather than just going from dispensing people who have been on daily supervised, who may not feel that they want all their medication at home, and they may want some contact with the pharmacy for support. So we've done it case by case in dialogue with our local pharmacies and the patient, and see if there's any assets or other people who can help with collection, or we have provided people with locked boxes, naloxone kits and measuring cups, as well as information about drug-related harm. In terms of people who are shielding and are on the government's list, we have got that information through our local IGB who are sharing that with us, and we would go out. First of all, we'll check with people if they have a family member who may be able to collect their prescription for them, and we would come to that arrangement, again depending on risk and what the patient and family feel they can cope with. But we would also, we go out and we have a rota of using everyone within our integrated joint board. We've got social work staff, nursing staff, we've pulled in some criminal justice staff, and we're looking at occupational therapists and some volunteers, and we will deliver the medication to anyone who needs to shield or anyone who should be self-isolating. We do also have a cohort of very vulnerable people that isolation brings up more of a challenge, not just in terms of physical health but mental health, and we have been going out to them also and delivering their medication to them at home, as well as checking people have necessary things such as food parcels, any sort of contraception or feminine hygiene. So we have been managing to do that, and our primary care colleagues are sharing that information, and we're very lucky. We're now training anybody involved in that, including housing, on naloxone, so they will be able to do the provision of naloxone during this time, which is really good for increasing people's awareness across their integrated joint board around drug-related harm, some of the real issues that people face. We haven't had huge issues with supervision, but we can supply from our own premises. So when we're starting people, if there's some delay for the pharmacy taking someone on, we will offer supervision, and we have done that from our own premises until we can get pharmacy provision in place. And we try and work, as I say, as Carole says, we try and communicate with the pharmacies and see how, what we can do to support them to continue to take people who have been liberated from prison or are new starts. We also work very closely, and I think the communication and partnership has been absolutely necessary. We work in partnership with MELD, who provide our IEP service. Now, the majority of the nursing staff can now also do that if they are out visiting people or people are still coming into the clinic. Elaine Elder, who works for MELD, has done some fantastic work when she's seen people on a set of outreach. So she's doing door-to-door needle exchange, and she's been able to refer people to herself and to other health professionals around wound care. Things like if people, again, she's in contact with them and they need food bank referrals. She's actually, her transactions have been up, and over the last few weeks she's had 54 transactions, so there's still that great need for this service. And she certainly, myself and Elaine have done some really good work around anyone who's not in treatment that she's seen, and I have went out with her, or have went out to the house and then done titrations from home for people who are self-isolating or can't come on. Anyone who's fallen off their prescription, we have also, who are self-isolating and then have missed so many days, we are doing going out to them at home and using PPE and supervising methadone for them at home and retitrating them from their home environment. We also receive daily lists to try and keep people as safe as possible, as ever changing for people as the risks work with people who are isolated in terms of their own drug use. We get a daily non-fatal overdose list, and we assertively outreach to that too. And what we would be looking for to see if there's any difference on that list from anyone who is on reduced dispense and has that created a higher risk for them, and we'd be able to respond to that fairly quickly. And that would also highlight anyone who's not in treatment, because that's a population we want to try and support during this time. We are all at work. There's not really anybody who can work from the base. Well, we are still full staff complement, luckily enough, with just one member of staff unable to come in. So we are continuing to assess people within our building and at home and titrate people. We are still getting new referrals, and we're doing a telephone triage and then rapid access to treatment, as well as offering any other needle exchange. And I think the BBV testing, we could offer venopuncture to have them processed. And one of the big issues for many people we continue to prescribe OST to is the isolation, the lack of one-to-one face contact. So along with our third sector colleagues, there's a Zoom meeting most days, and that's not, there's smart recovery, obviously there's mutual aid Zoom meetings going on just now, but we actually have Zoom meetings for the population that we would usually see at a drop-in that we previously run. There's some issues about access to IT, and we're trying to address that, but we have daily contact through social media for that group, and Third Sector are leading that, but it's a really good way for service users to remain in contact with us or highlight if they've got concerns. Some of the challenges that I'm certainly seeing in terms of the challenges that people face in their families is there's a reduced supply in some areas that we live in. There's reduced bus services for attending appointments, but certainly the reduced illicit drug use supply does appear to be a huge issue in this time of isolation. And what we're seeing is a reduce in heroin use, but great use of Xanax and other illicit benzodiazepines. And we're not quite clear yet, what the response would be, but we're doing it case by case. I had a look at Andrew McCauley's paper, and we would want to look at some response perhaps going forward around that. The other issue is when people having people who've relapsed or people who are continuing to use, and our advice would always be to use in company. You can't use naloxone on yourself essentially, and that's an issue, and it's trying to get people themselves to risk assess what the risks are for them if they're using alone, or is it a risk of COVID. So we have to have those really open conversations with our client group who are using drugs and on prescribed medication. One of the other challenges that I see going forward generally is the out of hours provision. If pharmacies have got reduced hours, perhaps services are under huge demand, and we would like to maybe look at peer naloxone and how people access kits out of hours, or if they run into problems at the weekends around self-isolation. So I guess we're continuing, certainly Mid-Lothian have got a fantastic nurse and social work and Third Sector team to offer the service as much as we can in case by case, but be keen to hear what other areas are doing so that we can learn and share experience, because I do believe there's going to be an ever-changing picture, and you're almost expecting the unexpected just now. Thank you.
That's great. Thanks, Tracey. Okay. Yeah, perfect. Yeah, we'll come back to you. We'll come back to you at the end for questions. Our third speaker now is Laura Rothney, who's a senior nurse practitioner from Aberdeen Substance Misuse Service. Now, unfortunately, technology has let us down with regard to Laura, so she's not able to be on camera. But we have her logo of from her service, so you'll have to view that when she's speaking. Laura, over to you. Thanks very much.
Thank you, Dave. You just get my voice, unfortunately. So I oversee the nurse and staff team within the Clinical Substance Misuse Service within Aberdeen, which currently has approximately over 1,600 individuals open to the service. Up in Aberdeen, we are still working a normal 5-day service. Apart from we have went on to a back-to-back rota with nurse and staff, so we are on a skeleton staff within what we've created as a hub within the office. We are still accepting referrals. At the moment, we haven't seen a big change within what volumes in comparison to other months, but I think one thing we've definitely noticed is it's making sure we can still provide a safe and quality service. So within our assessment clinic, we've got the opportunity for high-risk clients to be seen. So what we did initially around 4 weeks ago was nurse and staff went through their caseloads, a bit similar to what Tracey said, doing a traffic light system regarding risk. Within this, we've really went mainly to face-to-face contact and provided up to 50-60 prescriptions to the pharmacy. The assessment clinic at the moment is just being utilised for high risk, so prison liberations, new assessments, anybody that's maybe disengaged, fallen off their prescription can be seen on a face-to-face, and then it moves on to telephone contact. Thankfully, so far, it's been quite positive in terms of managing to get individuals over the phone, still having to use a lot of other agencies' contacts, so utilising a lot of support from the pharmacy. We're maybe in a better position in terms of supervision. We've still have a number of patients that are on consume on premises. Some have been relaxed when it's been appropriate, but maintaining that high risk patients that have been identified, they're still being able to go into the chemist regularly. We have a few patients, I think at the moment maybe around 10 within the service that are shielding or self-isolating. We've managed to arrange a standard operating procedure, so we've got clear guidance on how we manage these patients accessing services and their medication, ideally through a nominated person, so utilising family support, other people within their support network. Thankfully, through nursing staff, we have the capacity at the moment to deliver methadone if required. So if there's nobody appropriate within that person's lives, we've been doing that on a weekly basis, delivering methadone to patients' houses during their self-isolating period. We are mainly utilising postal naloxone and are injecting equipment through commissioned services, which has been great. They also have ongoing virtual groups and WhatsApp support that we can tap into for our patients that are open. They've also got a helpline that we're able to signpost patients to. The service has developed a nowhere to turn to leaflet that each patient's been sent out of services available, especially around things like if they've got issues with gas and electric, or utilising and getting food now that a lot of food banks within the city have shut. So that's been quite helpful. We're lucky we don't have any kind of staff redeployed at the moment. Initially we had a couple of staff off, but at the moment I don't want to jinx it, but we're pretty well staffed. I think our only concern at the moment is, like Carole was saying, was that significant strain on pharmacies. So making sure people are aware that they need to social distance, that there might be a bit longer of a wait at the chemist. We're working quite closely with HMP Grampian in terms of forward planning for any liberations that might be due within the next 3 months. So it's making sure that pharmacies are included in that, so they can create the capacity for anyone getting started on methadone or any other OST. But I think, again, like Carole said, it's mainly been communication, ensuring that we're kind of all working together. A lot of relaxed suspension has been a multidisciplinary approach, so if making sure that how they present at the chemist is how they would present at normal appointments in terms of concerns. I don't think there's any other concerns we've currently got at the moment.
Thanks, Laura. Is that you finished?
I think so. I think we seem to be in a bit of a different position. Unfortunately, Tracey's got the option of assertive outreach. That was a test of change that we were currently looking at before COVID hit. So we do have outreach through third sector. So I suppose that's one thing we have. If we aren't getting a hold of people, we do have the option of people going out and chapping on doors.
Okay, that's great. Thanks, Laura. Can we bring now the three of you back for the question session? And also Austin, who's been looking at the questions. As we're doing that, I suppose maybe it's a question for all of you in terms of the capacity for new OST starts, and how straightforward that is. Laura, do you want to start with that?
Yeah, we are still taking referrals. Our referrals mainly come through third sector or GP. At the moment, we have capacity to pick up people within staff's caseloads, and thankfully, I think we're still managing to get that care transferred over to primary care as well at the moment. I think one of the challenges we might have is that we have a huge increase in people getting liberated from prison, because we would automatically have to absorb them into the service because they're already prescribed OST. So depending on that numbers, there is that concern that we might have to then build up a waiting list of referrals coming from primary care.
Right, maybe anyone else want to talk about swift access to or for new starts on OST. You've mentioned that already, Tracey, but you were also doing assessments in people's homes or on the doorstep.
A mixture. So we do a mixture. So we do get referrals. Say from our referral this week was from the assertive outreach needle exchange. So I picked that up on Wednesday afternoon, and that gentleman was started on a script on Thursday. So he's now in treatment on a prescription. And we are doing self-referrals. People are self-referring. I've done a same-day start this week from a gentleman who phoned up just saying that because he was struggling to access heroin, that he wanted to now come into treatment. So it's a lot of self-referrals. So they'll phone the service, we'll phone them back and do a telephone triage and then bring them in and assess them. The needle exchange person was self-isolated, so we went out to the house to start him, myself and a social worker. So we're still getting the same, there seems to be still a same volume, but it's quite interesting this week. It's 2 people who have never been in treatment for some time in the last couple of days are now saying that we need rapid access because they can't access heroin the same.
Okay. Carole?
Yeah, I don't know if you can hear me, but I have lost all the pictures somehow or other.
We can hear you though. So.
Oh, you can hear me? Okay, yeah. No, the same picture. I think as Tracey and Laura have described, we still have capacity for some new starts, and similar picture that we're seeing. We're seeing new patients coming forward, and we do still have some capacity within the pharmacy network. And I think the fact that we've worked very hard to reduce the impact in the first few weeks and a lot of reduced supervision and reduced attendance has helped us to maintain that capacity so that we can cope with new starts.
Yep. Just maybe going back to Laura's point about prison releases as well, I wonder, Carole, obviously there's plans in the prison system to move most people onto Buvidal, which is the long-acting buprenorphine. Have you any thoughts on that, Carole? And also, obviously, in terms of if most people are being moved over to Buvidal, what about the issues around continuity of care in the community?
Well, I think certainly from a Greater Glasgow and Clyde perspective, we have had a very successful pilot of using Buvidal, and I think around 47 patients. I don't know that it's not the answer for everyone. I think people should have a choice, and buprenorphine is suitable for some but not for others. It does, I suppose, give you a bit of breathing space. So I think there are potential benefits in terms of reduced supervision and reduced contact. But people coming out of prison are at the most vulnerable and likely to experience overdose. So I don't know that. I think there's some disadvantages there about potentially not having contact with services immediately they come out.
Yeah, Laura?
I think Carole's hit the nail on the head. There's pros and cons to it, but I think that contact after prison, we know that they're a very high risk group for overdose, so they're the people that I suppose we would really be wanting to see initially face to face in some respect, so we know who these people are and we're building some kind of rapport with them before we put them onto less contact through the telephone.
Yeah. Tracey, do you want to add to that?
Quite a few prison libs. We do an allocation meeting with Community Justice Scotland in our area to try and highlight people who may be on an early release list. So we've got some awareness we might be expecting to come to be liberated from prison. We try and see people face to face when they come out, and we have been we are seeing people to prescribe, and then they're a cohort we would try and see or liaise with the pharmacy about how they're presenting. But certainly the first contact, most of our prison liberations are coming into service still.
Okay, thanks. I'll bring Austin in a second in terms of other questions, but I suppose a crucial one that I wanted to ask first was just around the contingency planning specifically for pharmacy closures, or if that is a possibility. Carole, I know we had a brief chat around that yesterday or the day before. Do you want to comment on that first?
Yeah, I will do. Pharmacies are all independent contractors, so they all have their own business continuity plan. I mean, a lot of these plans have come into action in Glasgow previously for individual incidents where pharmacies were suddenly closed. At the moment, certainly in Greater Glasgow and Clyde, although they're operating on reduced hours, they are managing to keep the whole network open, and I think that is something that we certainly want to continue. The contingency plans are the same as really for any other service. They maintain essential services, and certainly OST provision and IEP equipment provision are essential services that should be maintained. Other things have been stopped just to allow them to continue to do that. And a lot of the premises, I don't think we've seen yet the full impact of a reduction in the workforce. So at the moment they're all open, but it's the same as others. What would happen is they would retract into bases in the same way. But I think going back to the original point, communication is essential here about what's happening, what the hours are, and when any closures are going to take place. But so far, the network is functioning.
Okay, thanks. Tracey.
We, similar to what Carole's saying, a lot of the pharmacies are independent contractors, but certainly we're working closely with our lead pharmacist, and it would be about communication and what we would need to do if there were a pharmacy closure in our area. It would depend on the volume, but some of the contingencies are around us supervising doses, as well as other areas and loading using a centralised place. So I think we're aware this may come up or switching to Buvidal, which we could do as a named patient if it was the right thing for a patient just now until it goes through our local formulary. But certainly we are looking, just as Carole says, at all contingencies and there is a full contingency planning about moving that, and it'd be about the pharmacists communicating if we needed to offer any support. But they are independent, so we wouldn't have, but they certainly would need to maybe ask us to look at alternatives to dispensing. And we haven't run into any problems with pharmacists.
Sorry, Dave, if I could come back in there, I think it's important that we keep as wide a geographical spread as possible. For example, if there's 2 pharmacies and they can each only open, have one pharmacist between them, it's better having them 2 open half a day in different areas than 1 in terms of travel and local access.
Yeah, that's helpful. Laura, do you want to add to that?
I think we're in a similar situation. We're lucky to have 2 specialist substance misuse pharmacists within the service, so they're really good at keeping us up to date locally and nationally in terms of what's happening regarding the pharmacies. I think, again, we're the same, looking long-term planning at what ifs, where will we go if pharmacies start to shut further.
Okay, thanks. I'll bring Austin in at this point, who's been diligently looking at some of the questions coming in, and hopefully there's been some, Austin. You need to unmute yourself first of all so we can hear you.
I can't unmute myself. Here I am, yes.
Oh, yeah. Well, somebody has to.
Yeah, there's some kind of hierarchy. Yeah, there was a lot of questions come in at the very end, and I'm trying to group them together in sort of themes, given that we're unlikely to have the chance to answer them all. And on that, we will try, and this is the first webinar, but we will try and find some way of publishing the questions and answers, even ones that we don't manage to answer just now. The first thing is that there's a lot of interest in the postal supply of naloxone, how that's done, and how we get over any sort of technical barriers about it being a prescription-only medicine or providing it with training.
Okay, I'll put that to Carole as the pharmacist in the room, or on the webinar anyway.
Well, I think postal supply of naloxone is probably the one thing we don't have in Greater Glasgow and Clyde, despite having really good coverage and a huge range of agencies and peers involved in the supply. But there's no barrier to sending prescription-only medicines through the post. I mean, it is used in rural areas at some time. So I don't see any barrier to that at the moment.
but you're not looking to introduce it
Well,
yourselves?
as I said, no, I think in the rest of Glasgow and Clyde, I think we have really good access to the naloxone. We still have most of our sites open. We're using the IEP van, and John Campbell, a lot of your audience will be familiar with, has organised a team of volunteers, and the van operates 7 nights a week. And they have supplying naloxone through there. So yeah, and with all the changes in prescription that have gone on, it was very important that naloxone was supplied at the same time. So we have good coverage.
Yeah. Okay. Thanks, Carole. Laura.
It's one of the options we'd looked at because we don't have patients really coming to services. So our third sector colleagues and our nursing staff here can do it, mainly just going through the checklist. Majority of our patients are already trained. So it's just having that conversation that they feel confident and competent in terms of administering it. And if clinical staff and the person who is going to be receiving the naloxone is happy, that's then just the A-OK to get that posted out to them. I'm not too sure in terms of numbers how many people have used that yet, but it's certainly an option by itself or along with injecting equipment.
Thanks, Laura. Tracey?
We haven't moved to post on naloxone yet, but it's something I did raise with third sector following the key informants meeting. As other people are using that. We haven't down the route, as Carole says, of any prescription changes or any deliveries. We're taking the naloxone out with us. And I've been training people to supply, the resupply of naloxone from, as I said, from criminal justice to housing to social work staff to try and get more people. And we are looking to move on to what we could do for weekends and evenings if people can't access services. So we're looking to maybe move on to some peer-to-peer naloxone as well, but it's certainly something if we could ask. I did speak to Elaine, our third sector worker who does the needle exchange around us. It's something, is there a demand for it in our area?
Okay, thanks. And it's also worth maybe noting that many areas have moved to injecting equipment provision through the post and through a sort of click and deliver service or a click and collect in some cases. So that is likely probably to be, across the country at some point, I would have thought. Austin, another question.
Well, there's several questions around the kind of a treatment regime around daily pickup. So I suppose the questions fall into how do we protect people in terms of making sure that they can remain in treatment and that treatment be stable for them, but also protect people from COVID. So what do we do about people who we would otherwise be advising to socially isolate because they're symptomatic or somebody in their household is, but we've got them in a daily pickup for other reasons? So how do you balance those two risks? Have we considered the impact for children and parents on children having to accompany their parent to wait in a queue outside a pharmacy, as has happened? And is it possible, or have we found a way of allowing people who are in treatment to opt into daily pickup if that's what they actually want to do, to maintain their engagement with treatment? I think that covers 3 or 4 questions.
Yeah. Okay. Tracey, do you want to, if you can remember the whole question?
Yes, I think we spoke a bit about that. We've not taken a black and white approach to saying you're either shielding and you're at risk or you're not. What we did find is some people would phone and say, I should be shielding so my 80-year-old father will pick it up, and you're like, actually, that's not we can't opt, that would be a plan because he's equally just as vulnerable, not on the shielding list, but just vulnerable. So that would be the cohort we are delivering to, that population I talked about who really don't have another member of the family. And we do have people who aren't shielding, but actually from a mental health and isolation point of view, their risk would be around they're at higher risk of death, or even some people have found, it's just really, really difficult, and they want some contacts. We've negotiated with them what would be the best care plan for them individually. So we haven't got a kind of a standard operating procedure that's black or white. We're doing it case by case and it's changing, but certainly we will deliver to people ourselves, and we have 2 rota shielders, people who are shielding and people who are symptomatic. So we've got 4 people a day going out from a pool within our workplace. It's not just substance misuse.
And those are people that have been redeployed from other services?
Yeah, so they're just given time up in their rota, yeah. And there's a buy-in. We've got, we're quite lucky that we are seen as an essential service. I think we're actually busier than we've ever been over the last few weeks. Trying to meet the demand and trying to keep that quality of care and keep people safe and supported. And people are still coming into our building as well, and we've got the protective equipment to see people and review them if that's or we have to supervise their dose if that's necessary. So there's not one, one way we're doing it. We're just trying to make the best of, to tailor it to people's very different needs that are changing as well.
Yeah,
Carole?
can I come in? Thanks, Steve. I think I would just echo what Tracey and Laura have said. This is about individual risk and needs assessment. And in terms of daily pickup, and I think whoever asked the questions or the combination of questions, it's right. They're right. This is a balance of risk, and we shouldn't be exposing anyone to the risks of standing in the queue and extended waiting times. But it's a balance between, minimising the exposure but still keeping people safe. So it has to be really an individual thing. I wanted to pick up on the bit about opt-in for people who want to attend more regularly, and I think that's a really good idea, and it's something that should be part of an individual care plan if that's needed.
Laura?
Yeah, I think although we do have a standard operating procedure, I think it gives staff more reassurance in that everyone's kind of working collaboratively, because it won't fit everybody. I think it is coming down to being a bit sensible in that decisions and having that risk assessment around it. You might have somebody that their only structure to their day is going to the chemist every day. So if we take that away, what is the risk of them becoming more isolated? And then you might have somebody that's really anxious about being in the chemist because social distancing's not happening. So it's just taking it one by one and looking at it in the team of what suits that person at that time, and it's regularly reviewed.
Okay, thanks. Has Austin disappeared now, or are you still there?
Yeah, no, I'm still here, Dave. I was informed by the technology to turn off my camera, which I'm not taking personally.
Put it back on. We need to see you as well.
Well, apparently it was interfering with people's enjoyment.
Oh, was it? Okay, sorry. Oh, maybe that was it. If it was interfering with people's enjoyment, that's a different thing.
There's several questions around, I suppose, working with people who can't or won't engage. So what's been done with people we're trying to reach out to and work with via telephone if they're not answering the telephone, and has anybody found a way around the digital exclusion issue where people haven't got a phone or aren't able to use online technology to speak to workers?
Laura, do you want to talk to that first?
Yeah, I think the technology was always the concern because not everyone has access to technology. So it's coming back to really relying on any other professional that person maybe works with. So if we're not getting them a hold on the phone, are they going to chemist daily? How are they presenting? Working alongside, we've really increased our links with housing, with people that have disengaged. Some other agencies like housing or third sector have been able to do outreach to go and knock on the door to see if they can get in contact with them. Our next line is if we can't get hold of them at all through any agency, would maybe to do a keep well check through Police Scotland, just to ensure that person's safe and they're aware that they can still come back and access treatment.
Tracey?
I think we haven't come up across the issue of anybody self-referring and not having a telephone number, but we are assertively going out to reach people. If they're a non-fatal overdose, if we can't get them via telephone, we do go out and chat to the door, we cold call. We use our assertive outreach team in third sector or ourselves buddied up with them. So we do assertively try and when they're doing it, if there's a needle exchange transaction, someone's not in treatment, we are saying if you give us our details, we'll start you on treatment. And one of the cases is we went out to start that treatment at home because that was the only thing that individual felt he could cope with due to physical health problems. So we are really assertively trying. Now, some of the issues are around access to technology for Zoom meetings, and that's another issue when people are really isolated. So that's something we're trying to address and see if we can get some money to provide people who really want to engage. So we're just trying again a variation, but we do go out and do welfare checks as well on people if we haven't seen them or if they fell off their, they've not collected a prescription from the pharmacy and the pharmacy make us aware. We will try and get in contact and we will do a welfare check first to see if we can re-engage someone.
Where are you seeking to get funding for the technology or smartphones?
With the Scottish Recovery Consortium, Jardine's team about some of that money, but I would also speak to local, if I can, if that money's not there, maybe local ADP to see if we have a small group of people who are very keen and were very engaged with us, who don't have the resources to purchase a phone that has that type of technology. And it's not many people actually that have came forward, but I do hope we can get that from somewhere. If not through the consortium, we could try and get some money from our local ADP. Okay, thanks. Carole, do you want to say anything?
Yeah, slightly outside my comfort zone. I'm being digitally challenged at the moment. I can't see anybody, so I hope you can hear me.
We can see you as well, Carole.
Can you? No, you can't.
Yes, we can, yeah.
Right.
I should have mentioned that earlier.
Welfare safety checks, yeah, we still have staff and capacity to do that. And like Laura's just said, in terms of the technology, I think our staff are looking at phones, and I think that's through the Scottish Recovery Consortium as well.
Okay, thanks for those. Austin?
There's a couple of specific questions, one for Carole, which I suspect I know the answer to, which is when will the Home Office move around the changes to legislation? And one for Tracey, which is there a protocol for home titration? And one for the whole panel, which is, I suppose the question that concerns us all is there any evidence of an increase or changes to the rates of non-fatal and fatal overdoses?
Okay, Carole, the Home Office.
The Home Office question, well, I wish I knew the answer to that. All I can say is, from what I have heard, it will be soon. It's proposed to be a time-limited piece of legislation anyway, so it really needs to be enacted soon to be relevant for the current problem. So initially it's supposed to be for a 3-month maximum period. That's all I know on that.
Yep, thanks. Tracey, protocol.
Sorry, what was my question?
It was about the protocols for home titration.
What's the, sorry?
For home titration of people.
What do we do? The protocol?
Well, more a protocol, yeah.
Sorry?
Yes, a protocol.
So we just use an existing, we were using a test of change clinical governance guidance around what makes it safe to initiate opiate substitute therapy. So that hasn't changed. What you're actually doing is doing toxicology in somebody's home, and you are looking for all the evidence that somebody needs this prescription. Just so all the checks are the same, except you're doing it at home. We have access to stock medication, or we can collect the prescription from the pharmacy and take it out in twos, and then we would supervise that consumption. So we have done it for buprenorphine, and we had someone who'd fell off, so someone well known to us who had symptoms of COVID, so just didn't go to the pharmacy and missed, I think, 4 or 5 days. So we just went out every day to his doorstep with a titration dose of methadone. And it's still using all the same guidelines, except you're just not doing it in the clinic, but you're using all the same paperwork and guidelines.
Okay, thanks. And the third question was to all of you around fatal and non-fatal overdose. Tracey, do you want to start?
So we haven't seen any increase in terms of reduced dispense, and that's something we're monitoring. And for non-fatal overdose, we're looking to see if anyone at this time. So there doesn't seem to be any variation. Certainly no one with reduced dispensings came up on that list as yet. So that's one risk that we try and mitigate. We also continue to get a report daily and a weekly report from Scottish Ambulance Service, and that information in the first instance, if it's someone that looks like they need OST, we would contact them, and Elaine Elder would also, from the assertive outreach team, does actually assertively go out with someone else and chat the door to see if they want treatment or they need an naloxone kit, and if it's anyone on our caseload, we follow that up as well. So we get daily reports, so we're still acting on that in the same way as we did prior to COVID and managing it as it stands.
Carole? Thanks, Tracey.
Yeah, I think anecdotally, what we're seeing is an increase in use of naloxone in the community. Now, whether that is linked to the fact that presentations at A&E have reduced by around 40% in Greater Glasgow and Clyde, but that's A&E presentations across the board, not necessarily for overdose. So we're trying to unpick that at the moment, but certainly there seems to be anecdotal evidence that more naloxone is being used in the community. So whether that is linked to more numbers or just numbers that are not reaching other sources, we don't know. But I think with the increase in polydrug use, the increase in alcohol, and all of these central depressant effects, I think it is a risk that we all have to be aware of, and I think that makes it really important that naloxone coverage is as wide as possible.
Thanks. Laura?
I think everyone probably involved in this has got the same concerns regarding availability of drugs, people getting more takeaway methadone. Will there be an increase? I think it'll probably be a long time until we can determine that, you know, if that factors are related to our overdose. We're the same, we get the Scottish Ambulance reports. We have had a few in the last week. I'm not 100% sure if that is higher numbers than normal, but it's certainly something we've been monitoring, and that would be one of our kind of key points to keep focusing on during this time.
Okay, thanks a lot, Laura. Austin, have we exhausted the questions or not quite?
No, I'm afraid not, and I have to apologise to people who perhaps feel excluded. I'm hoping to, with some of the more technical or factual things, just to be able to find some way of getting back to people. One of the last one, bearing in mind we've got 2 minutes, would be about Vividal, about the use of it in prison and continuing that use out in the community when people are released. Is that possible in all health boards if it's not been approved or it's not been used locally? And is there the potential to put more people in the community on Vividal?
Carole, I know we've covered that a bit already, but do you want to add to that?
Well, I mean, I suppose it should be on your local formulary before it can be prescribed. That doesn't stop people from prescribing it, but normally it should be on your formulary. If some services are able to store Vividal because they have a home office license that allows them to do that, others don't. And if there was a sudden huge increase, I don't know what the supply chain would be like, whether they'd be able to cope with that. So there are pros and cons in that. So I think it's potentially possible, but the staff, I think there's only been small pilots within Scotland, so there's not a lot of experience of actually using it.
Okay, thanks. Laura or Tracey, you want to add to that?
I think we've been quite limited in our trials with it. I'm not aware of HMP Grampian's plans of releasing people on that. They're normally getting released on their normal medication, which is either aspirin or Suboxone or methadone. So I think we are very early days compared to other health boards.
Yeah.
Okay, thanks.
I would just mirror what you, Laura's saying. We have not really seen that, and we are trying to get it through our local formulary in terms of community prescribing, but certainly I'm not aware of our local prisons releasing anyone on Vividal.
Okay, thanks very much. Well, I'm afraid we're out of time, but hopefully you've enjoyed this webinar and that it went reasonably smoothly. It certainly seemed to from our side, but we'll know when we look back on it. And just to say, we have recorded the webinar and we will put it up for others to view it, or even if you want to view it for a second time. We'll also send out a short evaluation, and it would be helpful if you could complete that, given this is our first webinar. And finally, just to say, we're currently planning another webinar for the same time next week. We'll look at issues around homelessness and substance use details. I'm not sure whether they've gone out already, Austin, or will go out today.
Soon with the evaluation, hopefully.
Soon. Yes, soon with the evaluation, perfect. So hopefully some of you will be able to join us then, but thanks for joining us, and goodbye.